Now let's discuss its clinical features. First, general features. As I told you in pathophysiology that giant cells and macrophages produce some acute phase reactants, which then go into circulation, and just in any kind of inflammation, patient will complain of low-grade fever, generalized body aches and pains, along with some unusual fatigue. There could be anorexia, and sometimes there is weight loss as well. Now come to specific features. It is most common form of vasculitis in adults, so it should always be considered as a differential diagnosis of headache in 50 plus patients, especially when you get very high ESR in labs. Such patients are often misdiagnosed as having tension headache. The headache is continuous and throbbing in nature. Mostly it is temporal, but it can be occipital. Common complaint of the patient is scalp tenderness, especially at the time of wearing hats, glasses, or combing hair. 50% of the patients can have superficial erythema and tenderness, and a thick temporal artery can be felt between two fingers. Another important feature that patient reports is jaw claudication, which means pain in jaw while chewing food. There is obviously a vascular cause behind it, and this is because of ischemia of masseter muscle, which is supplied by maxillary artery. A rare manifestation is tongue necrosis, which is because of vasculitis and occlusion of lingual artery. Now let's come to a symptom that makes it a serious condition. That is involvement of eye. Eye manifestations can be in the form of visual blurring, diplopia, or amaurosis fugax, which means transient visual loss. Initially, these symptoms are unilateral, but if timely treatment is not started, they can worsen and affect the other eye as well. During eye examination, partial visual field defects can be found, which can then progress to complete blindness in untreated cases. Sometimes the visual loss can be abrupt and painless without any warnings. Out of all eye symptoms, the most common is anterior ischemic ophthalmic neuropathy, which is vasculitis of posterior ciliary artery. Fundoscopy may show chalky white pallor disc with edema. Eye manifestations other than anterior ischemic ophthalmic neuropathy are posterior ischemic ophthalmic neuropathy, central retinal artery occlusion, branch retinal artery occlusion, and choroidal ischemia. These can manifest as any of the findings I told you before, like visual blurring, transient visual loss, or partial visual field defects. So when you suspect eye involvement in giant cell arteritis, complete eye examination is must, including visual acuity, pupils, visual fields, slit lamp examination, and fundoscopy. We should always instruct the patient to immediately report a doctor if he experiences visual symptoms at any time during the course of disease. Now that we have discussed the more common symptoms, keep in mind its less favorite sites. Sometimes the patient with involvement of intracranial arteries can present as stroke. Similarly, coronary artery involvement can lead to myocardial infarction. Involvement of aorta can lead to aortic aneurysm or aortic dissection. Apart from these arteries, other arteries like carotid, axillary, and brachial should be assessed for bruise.